Hi, my name is Elliot Sterenfeld, and I'm a physiatrist and part of the neuroscience team here at Lancaster NeuroScience and Spine Associates. I joined the practice in 2001, and I bring a specialty of non-surgical diagnosis and treatment to patients dealing with back pain or pain due to some spinal origin. I went to medical school in Chicago, completed medical training at Northwestern University in 1989, and then traveled to Philadelphia, where I started out my life there as a general surgery intern, and then went on to complete a residency in physical medicine and rehabilitation. I then completed a specialty year of training as a fellow in spine at the University of Pennsylvania. In fact, that was the first and at that time only academic fellowship for non-surgical spine care. So I initially became a physician, I think as many doctors do, with an instinct to help people in some way. Many of us are good scientists, good science students, and we want to find a way to apply those skills in a way that hopefully has some altruistic ideals to help folks out who need our help people who are in difficult situations. During my training as a medical student, certainly was interested in many of the fields that I was exposed to, and in fact started out my training after medical school as a neurosurgeon. But after my first year or so of training as a neurosurgeon, I began to feel that I could actually apply my particular skill set better as a physiatrist, focusing on the non-surgical treatment of patients with neurological or musculoskeletal problems. Physiatry is a kind of little unknown field. It's actually been around and an official specialty of medicine since the late 1930s. It is a wonderful field that has always taken the approach that the patient is at the center of care, that we are all focused purely on the patient's needs and ultimate functional outcome, no matter what the disability, no matter what the impairment or disease might have been that affected their lives. Our goal is always to restore them to their maximal functional capacity so that they can rejoin life, whether they are a homemaker, whether they're a top executive, whether they're an athlete. They want to get back to their function of life before they suffered whatever injury or disease process that interrupted their life. Physiatry is a practice that has always been based on team-based approach to care. The physicians, the physiatrists, focus on working with a team of specialists, including physical therapists, occupational therapists, social workers, psychologists, the whole gamut of healthcare workers who literally come together and focus their attention and their skills around the individual patient and tailor whatever treatment skills they have to the needs of that patient. It is a very rewarding way to approach patient care because we know that we can't always cure people, but healing is always possible, and relieving pain and relieving suffering is always possible, even if ultimate cure is not the realistic goal. So the field that I practice is officially called interventional physiatry. It's a difficult word, physiatry, one that I'm still struggling with. But again, it's the specialty of physical medicine and rehabilitation. And this small field, this subspecialty of spine care really came about in the latter 1980s, early 1990s, where before the care of patients with spine problems was either left to surgeons or to the primary care doctors, and patients really had two choices: either do nothing or have surgery. And as the years passed and research became more sophisticated, we began to realize that there was a whole lot that could be done for people in between those two extremes. And that in fact, the vast majority of folks with spine problems, whether it's due to a disc herniation, a sports injury, stenosis, arthritis of the spine, there's a great deal that can be done to relieve their pain, to relieve their suffering, to restore their function that does not require surgery and is certainly more sophisticated than do nothing. In fact, medicine is always changing, we're always learning, and not so long ago the treatment for most back problems was to lay in bed for a week to 10 days and take a lot of medication, and then that was all you had. As time went by, we've discovered that in fact bed rest is not the best treatment for spine problems, and in fact it's detrimental to most people's state of health and certainly their back problems. What we've developed over the past 20 years or so now is a fairly sophisticated approach to spine care that first and foremost tries to focus on defining and refining the diagnosis. Is it enough to know that you have a specific disc herniation or not? Do we need to know which nerve is causing pain or which set of joints are causing pain? For many patients, the good news is if they have an episode of back pain, it's going to get better pretty much on its own within a matter of a couple of weeks with some reasonable treatment like simple medication at home, Tylenol or acetaminophen, not to promote any one specific brand, or ibuprofen or other anti-inflammatories, and some reasonable modifications to their activity, some reasonable exercises. They're going to get better by and large within a few weeks. But there are a whole lot of people who don't respond to normal care from their primary care doctor who need specialized care, and those are the folks for whom we believe we can actually improve their outcomes if we can provide a more sophisticated and more specific diagnosis and thereby a more effective treatment. If we don't know what's causing the problem, then we don't have very good treatment to address the individual's pain. Once we make a specific diagnosis, our chances of treating that person, whether it's non-surgically or surgically, are much greater, and the outcomes are far improved over the traditional and less sophisticated approach to diagnostics and ultimate treatment. To help us perform and arrive at some of these diagnoses, we've developed some specific techniques in the field. These techniques involve guiding needles to specific areas of the spine under X-ray imaging. In fact, our practice built this suite here, the center called the Center for Spine Care, back in 2002, so we could provide our patients with this type of sophisticated diagnostic and therapeutic treatment option right here on site. Using X-ray imaging, we can direct a needle to specific joints, specific nerves, or other specific structures of the spine to either treat the pain with injection of medications or perhaps by actually ablating or burning off nerve endings that are causing severe pain from joints, or by purely performing diagnostic procedures, again trying to define, is there a specific nerve causing the pain, is there a specific joint? Once we have that diagnosis, again, our treatments will be far more effective, whether it's non-surgical treatment or surgical treatment. The outcomes are far improved when we have more specific diagnoses for each patient. There are a number of procedures in our toolbox to help patients with their pain. A few of the ones that I use most often are procedures such as epidural steroid injections, injections to the facet joints, or the small joints in the back of the spine, often called the knuckles of the spine. Other procedures are purely diagnostic, such as discography, which is a way to specifically examine and test the discs of the spine to see if they're causing pain. Just to give you an example, epidural steroid injection has been around for decades. First started back in the 1950s to treat pain. Many women are somewhat aware of epidural injection during childbirth. It can be used to help numb the lower part of the body so women can labor and deliver more comfortably. Our use of epidural steroid injection is somewhat different. We're delivering medication called steroid, or what some people call cortisone, to the space that bathes the nerves of the spine in an attempt to reduce inflammation, reduce swelling, which will thereby reduce pain along that nerve and its distribution down the limb, whether it's the lower leg or the arm. The advances in performing these procedures are really quite considerable. Up until the 1980s, the most common way that epidural injections were performed were very much the way that women experienced them during childbirth. We would typically just ask a patient to kind of bend over or curl up on the bed, and we would, without any imaging guidance, puncture their skin and try to guide the needle into the right space just by feel. That technique is tried and true, has been around for years, and could often be successful, but often not. Over the years, we've developed a technique of doing these procedures under the guidance of X-ray imaging. This allows us to place the needle much more specifically, much more securely in the right spot, and frankly, it's a much more comfortable procedure because we're able to address the spine in a more gentle way under the X-ray imaging. Epidural injections are a remarkably safe approach to treating spinal nerve pain. And again, they're designed primarily for patients who are having pain emanating from the nerves of the spine that is radiating or referred down the limbs. It can be the upper extremity, the arm, or the leg. Epidural injections themselves are not great for treating typical low back pain without pain down the limbs. To treat back pain, we have a host of other procedures. As I mentioned earlier, there are structures called facet joints. These are the small joints that run up and down the spine. There's a pair of them, one on each side of the middle of your back. And they literally are just like knuckles, and they function like the knuckles of your fingers. They allow the spine to move in all different directions and handle the kinds of work we do every day. They can become arthritic, painful joints just because of life, because we've been bearing weight for more than a few decades, or because of injuries from a car injury or a sporting event. We can provide relief to those joints if they become painful, inflamed joints, just the way we provide relief to knees and shoulders and knuckles with injection of steroid or cortisone into those joints. Again, the difference here is we do this procedure under X-ray imaging, so we know specifically where the needle is, and we know with great assuredness that the needle is in the right joint and the medication is getting where it needs to be. That provides a more comfortable procedure for the patient and a far more successful outcome from the effort of the procedure. I think the things that I enjoy most about being a physician are essentially the human contact with my patients. I really enjoy hearing their stories, and I must say that I think that patients most of all want to tell their story, and that's perhaps the thing that is missing from modern American medicine because of a whole host of reasons, economic pressures, time, and everything else that is coming to play in our system of care. But most of all, patients want to tell the story, and they respond when they know someone is listening, when somebody really hears them and understands their life and how their medical issue is impacting their life. As a physiatrist, my focus has always been on restoring people to their life in whatever way we can, whether it's with procedures. Certainly I do a whole host of procedures, but honestly, only about half of my patients are going to come down to this suite and have procedures done. Easily half my patients I never touch with a needle because they don't need it. More often than not, a treatment routine will include medication and good physical therapy. I'm a firm believer in the value of functional restoration therapy to provide patients excellent response to, or excellent return to their functional level and relief of pain. Certainly, I get great reward out of successfully completing a procedure for a person and providing relief. There's certainly that ego that I have, that I like to do something to somebody and make them feel better, and they call 10 days later and say how much pain, how much their pain has been reduced. That's terrific, but I also just like hearing 2 months down the line that the person has responded well to our treatments, including physical therapy, and that they're back to doing what they want to do. They're back to golfing, they're back to playing tennis, they're back to just being a grandma and picking up their child or their granddaughter. Those are the things that we hear and we get back from our patients that I think keep all of us in the business of medicine.